Dean Galea is a physician, epidemiologist, and author. He's the Dean and Robert A. Knox Professor at Boston University School of Public Health. He previously held academic and leadership positions at Columbia, the University of Michigan, and the New York Academy of Medicine. He's published extensively in peer-reviewed literature and is a regular contributor to a range of public media about social causes of health, mental health, and the consequences of trauma. He's been listed as one of the most widely cited scholars in the social sciences. He's chair of the board of the Association of Schools and Programs of Public Health and past president of the Society for Epidemiologic Research and Interdisciplinary Association for Population Health Science. He's an elected member of the National Academy of Medicine. Galea received several Lifetime Achievement Awards and holds a medical degree from the University of Toronto, graduate degrees from Harvard University and Columbia University, and an honorary doctorate from the University of Glasgow.
Let me start by, what am I talking about? I'm talking about social. I'm talking about social context. I'm talking about the world around us. And by social, I mean exogenous, things that are outside of us. So by definition, I'm talking about things outside the skin. So I'm talking about use of substances, misuse of substances. And I'm not talking about genetics. I'm not talking about molecular processes. I'm talking about how is it that the world outside of our body influences risk of, tendency to, use of substances, and those becoming dependence, those becoming abuse. So it's really about the world around us. Now, so why do we even think the world around us matters? Like everybody on this call, it's safe to say, understands that substance misuse is a medical condition. We all get that. It's a core part of what we do. It's a core part of how we think. So then why are we even thinking about the social factors? Why are we even thinking about the world around us? And there are many reasons, I think, why we do think that the world outside the skin matters for substance misuse, substance use disorders. And I'm going to list those reasons. So I'll start with the obvious. The obvious one is intuition. Now, when, as Julie mentioned in the introduction, I've spent my adult life really in the role of a scientist, a population health scientist. And it is, I know, unusual to have scientists talk about intuition. It's not something that we like to talk about. We like to talk about empiric evidence, but I do think that's important to say, where does intuition have us start thinking? Where do we start thinking about things? And we start thinking about things from intuition. And the intuition that we all have is very simple. The world around us affects how we feel and how we behave. It's actually intuition that is that simple. I know that the world around me affects how I feel. I know you all feel the same way. And I know that I behave in different ways depending on the world around me. I'm just showing you pictures. These are pictures of New York City, where I spent a good 10 years of my life that I just took. Just to say very simply that, well, depending on where I was, the environment around me, the world around me, certainly affected how I felt and how I thought. So intuition is that the world around us, the social world matters. It matters to how we feel and how we behave, which then means it will matter for our use of substances. And I like to tell this story, which I think captures our intuition about how the world around us affects our health. And notice I'm talking broadly about our health. I'm not even talking about substance use, misuse yet. How the world around us affects our health by telling this story. And this story is about this man. His name was Willie Johnson. Those of you who know the blues will know him as Blind Willie Johnson. Blind Willie Johnson was born in Texas at the turn of the 20th century. He was born sighted, and the story is that he lost his vision at age 7 in a domestic violence incident. So he grew up poor and black and blind in Texas. He learned how to play the guitar, and he made a living busking, not a very good living, as you can imagine. He got married, and Blind Willie and his wife were living in a house, small house, and the house burned down. And they were fine when the house burned down, but they had no money. So after the house finished burning, it all settled. They actually went back and went living back in the burnt out husk of the house. When he was in his 40s, so it's Texas in the 1940s, Blind Willie Johnson got malaria. Now, this is Texas in the 40s. Malaria was not that uncommon. It's actually quite common. Many of you will know that the Centers for Disease Control, the CDC, was actually started to deal with malaria in the southern states. So there's nothing particularly uncommon about that. And his wife took him to hospital and he was turned away. It's not clear if he was turned away because he was poor, because he was black, or because he was blind. And then he died. Now, why am I telling you the story? I'm telling you the story to ask you the very simple question: what killed blind Willie Johnson? Well, what killed him was malaria, right? He died of malaria. Had he received treatment for his malaria, he would have lived. It's actually very straightforward. Malaria was what killed him. On his death certificate, it would say malaria. He needed treatment. Malaria would have helped him live. But why am I telling you the story? I'm telling you the story because everybody, you all know that it wasn't just malaria that killed him. It was also poverty. It was racism. It was domestic violence. It was poor access to care. It was homelessness. All these forces also killed him. Now, apply that to your work, to our shared area of concern, substance use and substance use disorders, right? Well, somebody may die of an opioid overdose, right? And that's what killed them. What killed them is the opioid overdose. But are we really understanding the opioid overdose if we don't understand the full set of factors in somebody's social circumstance that also surrounded their life and their death? The bottom line is that we're not. Is that we may deal with the opioid overdose today, but there's going to be something else tomorrow. Just like if blind Willie Johnson didn't die of malaria today, he would have died of something else tomorrow. So I think the story captures well how health is not it's not just the pathology that we're dealing with at the moment, but it's the full sum of factors that lead to health at that point in time and that fundamentally shape everything about our lives. So really it builds on this intuition that our health in any dimension is influenced by the social environment, and substance use and substance use disorders is no exception. So this intuition theory, there's actually abundant theory about this, which many of you did in your trainings, many of you use in your day-to-day work. The earliest monograph I could find from National Institutes of Drug Abuse on theories of drug abuse was actually in 1971, which is this book here, which was the year I was born. Norman Zinberg wrote this book. It's quite famous, The Drug Set and Setting. Some of you may know it. It's a good book. It was limited by the biases of its time, but fundamentally, he talked about the factors that determine substance use and misuse, include the drug itself, the local environment, and the context around it. So he really made this case, I think, fairly compellingly about 40 years ago, about the theoretical reasons why the world around us might matter. So I think there's abundant theory that sort of backs up what I said in my intuition. And then the evidence. There's also evidence. There's actually a large body of evidence, which I could summarize. I mean, I could spend an hour just going through study after study after study. That would be pretty boring, so I'm not going to do that. But that shows you how different elements of the social environment matter for substance use. This is a review paper, which I did in 2004, so now 17 years ago, which really summarized social environment and substance use. If anybody's interested, I mean, 16 years old now, I don't think anybody's redone it since. It would undoubtedly be updated and would actually give you a lot more information now, but I don't think the message in this paper has changed very much. And, you know, we talked about evidence around alcohol, around cigarettes, around illicit substances, and went through substance by substance and determinant by determinant and looked at how they affected substance use and misuse. So the evidence is no question there. And then I just want to talk for a second about organizing perspectives, because while in any of our disciplinary areas, here you've invited me to talk about substance use and its consequences, which means that's our disciplinary area for the purpose of this call. That's what most of us sort of spend our time in. But that is ultimately part of a broader concern with health and many aspects of health. And there are many organizing perspectives that help frame how we think about the determinants of health. This is my favorite one, just because it's very simple. I actually like simple frameworks. And what it says is, look, physiology, pathophysiology, which is the manifestation of a particular phenotype, be it, let's say, substance use disorder, is influenced by individual risk factor. Well, in order for me to have substance use disorder, I actually have to ingest a substance, right? But that ultimately depends on my social relationships. I may ingest a substance because I am doing it with you. That may be because of where we live. That may be because of the ready availability of substance in our neighborhood, which may be influenced by the fact that there are economic policies that make it not only plausible for us to do so, but actually perhaps the only thing we can do to find some pleasure in life, right? So these are all the elements of a simple organizing perspective, a theoretical framework that explains, that puts together how social economic policy, institutions, neighborhoods, living conditions, social relationships, individual risk factors all combine to shape individual phenotype and the manifestation of an individual in terms of their relationship to, in this case, substance use and misuse. So I don't think you can talk about substance use disorders without also talking about education, about aspects of somebody's education, without talking about the quality and the context of the family in which they grow up. I don't think you can talk about these disorders without talking about poverty and resources. I don't think you can talk about these disorders without talking about housing, availability of housing, stability of housing. I don't think you can talk about these disorders without talking about isolation, social contact, the extent to which that is either protective or a risk factor, absence or presence thereof. I simply don't think that the conversation around substance use and substance use disorders can ever be complete. And I don't think that a therapeutic approach can be complete that is not at least informed by an understanding of the social context surrounding the individual, who then is the individual of concern on substance use or substance use disorders. So having said that, having made that case building on intuition, building on theoretical perspectives, organizing framework, and the evidence, now it's sort of, to me, abundantly clear then that the social environment influences substance use disorders, substance misuse. So having said that now, what I want to talk about is, what are our challenges? What are our challenges in this? What are our challenges that define our scholarship and our practice? And I thought I would highlight challenges because in highlighting challenges, hopefully I am demarcating the limits of our knowledge to say, this is what we know, and beyond this is what we don't know, which hopefully can inform both scholarship and, for those of you who are more in practice, how you think about these issues within practice. Now, again, I could do a whole sort of semester about challenges, but I thought I would organize it in just three topics. I want to talk about our methods and the extent to which our methods allow us to wrap our brain around these issues, the constructs that we're dealing with, and the fundamental concepts. And I'll explain what I mean by each one. And within each one, I'm going to show you several challenges. And again, the point of highlighting challenges is not to say that we don't know anything. It's not at all. The point behind the challenges is simply to say that we know a lot until a certain point, and then beyond that, we are now stretching our area of knowledge and guiding potential areas of inquiry. So let's start with methods. I want to talk about three kinds of methods. I want to talk about social selection, confounding, and the role of time. And that these are sort of all terms that derive from my disciplinary home, epidemiology, but ultimately apply very readily to any range of approaches to thinking about substance use. Social selection is a fundamental challenge that we have in terms of understanding how social environment influences substance use or substance use disorder, because it is often unclear or often a reciprocal relationship, the extent to which somebody's social environment is causative of their drug use or their drug use is causative of their social environment. And this is something that you all know, informs much of the poorly informed media discussion about use of drugs. You see this all the time that says, well, you have poverty And that's surely caused because person X has a substance use disorder, rather than thinking of, well, person X has a substance use disorder because of their experience of poverty. And that is really challenging. It's really challenging methodologically. And the public conversation, what I call the ill-informed public conversation about this, and I do mean that, I think is reflective of some of the methodological challenges here. And I think you cannot speak about social environment and substance use without acknowledging the challenge of the two. Because the truth is deeply complex. The truth is that social environment shapes substance use and its consequences, and substance use shapes individual social environment. You know, this is a paper that our group had done about when marijuana use laws were being introduced. So the reason I'm showing you this is because from all my papers I've been involved in, this is my favorite title. And the title says, Adolescent Marijuana Use from 2002 to 2008, Higher in States with Medical Marijuana Laws, comma, cause still unclear. Now, in my field in epidemiology, we're all about understanding causes. So publishing a paper which says in the title, cause still unclear, is like publishing a paper that says, we actually don't know what the answer is, which it's a miracle, a major miracle that it ever got published. But I like this title because it's honest. It is honest that when we're looking at use of marijuana by adolescents, linking it to states with medical marijuana laws, it was unclear. There was a relationship. It was unclear if medical marijuana laws were causing more adolescent marijuana use, or because there was more marijuana use in the states, it was pushing legislators to pass medical marijuana laws. And it was an honest assessment of the challenge of the selection back and forth, that the social may influence substance use and the substance use may influence the social. So when we think about social environments and substance use from a foundational perspective, which is the charge I was given to talk about, I would encourage us all to recognize that there is often a tightly linked reciprocal relationship, that it is next to impossible to say poverty or lack of education or poor housing is causative of substance use and its consequences without also acknowledging it's the other way around. So that's challenge A. Sorry, every time I press my button, it keeps making a noise. Apologies for that. Unmeasured confounding. What do I mean by that? So unmeasured confounding means something very simple. It means that it doesn't matter what you're looking at, there's all sorts of other stuff going on that we don't understand. So the really cool aspect intellectually of thinking about social context and social environment is that it embraces a lot. It is about a lot. It is about a full set of factors that are broad and intellectually very interesting. The downside of that is that we seldom have a full grasp on which factor is the single one that matters. It is much easier to study genes and molecules, because when we study genes, I can say, I'm focusing on that gene, I'm holding everything else equal. Dealing with social environment, you're dealing with a whole bunch of stuff. And what I want to show you here is this was a study that we had done about cocaine overdoses in British Columbia, Canada. We had done with a postdoctoral fellow who was working with me. And on the y-axis, you have a probability of cocaine-related overdose. And what you have in the x-axis is population density. So what we're looking at, what we're showing is, you see how the left is higher than the right? So less dense populations had a higher rate of cocaine-related overdoses, which gets at the greater preponderance of cocaine overdoses in more rural areas, right? That's what that's getting at. But there was also something else that was very interesting, which is where the colorful lines are. Notice how the colorful lines are years 2001, 2, 3, 4, 5. Notice that? So notice how the line was getting steeper as we got to 2005, which means this relationship between less density, rurality, and overdose was actually getting steeper between 2001 and 2005, which is, well, why is that? Like, what's changing about the fundamental nature of people's place of residence between 2001 and 2005 that takes this relationship between population density and risk of overdose and changes it over that time period? The answer is, this is sort of where I come to unmeasured confounding. There are clearly other things going on that we actually do not understand. We certainly didn't understand those when we went into the study. We don't understand them today. So what I'm pointing out to is, when we think about the forces that drive use of substances from the environment, and they drive substance use disorder, are many and complex. And I think we're well served by a fair degree of humility that says we don't fully understand necessarily all of them. And that's okay. I think that's actually okay, because that doesn't necessarily have to lead to paralysis. It simply needs to lead to us recognizing that there may be conditions in the individual's life and conditions in the world around us that we do not fully understand that are causative, even if we don't know them. So it's the second challenge about unmeasured confounding. So that's the methods. Now let me talk about the constructs. So let me talk about the constructs. And by constructs, what I mean is the forces that we are trying to understand. So what do we mean by social environment? And what are these variables? Where are they? And how do we actually assess what unit of the world around us matters? So let me start with what we mean by social variables. And I want to give you an example of how complicated it is to isolate the social variables that matter. So we were interested, I've long been interested in the concepts of social cohesion and social norms. So I've all long felt that substance use and substance use disorders are influenced substantially by whether or not you are in a supportive community, that's social cohesion, and whether you're in a community where the norms are supportive of substance use. So by that I mean, social cohesion means you're a supportive environment. If it's a community with norms against substance use, it means you're in a community where people are going to frown at you if you're using substances. I've always thought that those two areas, those two concepts really matter. So we did this study. This was done in New York City. This is a map of New York City where we measured collective efficacy, which is a construct that's related to social cohesion. We don't need to sort of go into details, so I'm happy to talk about it in the Q&A. And we looked at the neighborhoods with the most collective efficacy. So the darker neighborhoods had less collective efficacy and the lighter neighborhoods had more collective efficacy. And then we looked at neighborhoods with norms. So the norm we're looking at is saying smoking is not acceptable, right? There's a norm against smoking. So we ask people this: is smoking acceptable? Yes, no. And then you measure it. And again, we went from less acceptable, which is the dark, fewer people think it's unacceptable, to more people think it's unacceptable, which is the light. So we could map out the city. We could map out the city by neighborhoods with cohesion and map out the city by norms that were against substance use. So these two constructs are important constructs. Well, then we did a whole bunch of fancy statistics to look at the risk of smoking. Here we're looking at smoking. And the way to read this is, there were three different groups of people. I apologize. The dark line are people who are living in neighborhoods where there were weak norms, meaning people didn't really care about smoking. This line here are people who are living in neighborhoods with strong norms, which means people cared about smoking quite a bit. Now, these lines, you see how they splay? Now, this is getting complicated. But here is low social cohesion, which means neighborhoods that are not closely knit. Here, it's high collective efficacy, which means neighborhoods that are closely knit. So look how the two go together. When there's low social cohesion, which means neighborhoods are not really closely knit, these three lines are very similar, right? Which means whether people care or don't care about smoking doesn't really matter if the neighborhood is not closely knit. If the neighborhood is closely knit over here, you see how this is over here, right here? The norms really matter. If there are norms against smoking, people are not smoking in these closely knit neighborhoods. While if there are no norms against smoking, people are smoking in these closely knit neighborhoods. So this says norms matter, but they only matter if the neighborhood is closely knit. So isn't that interesting when you think about it? Because now we're painting a picture of what aspects of the social environment matter. So you can say things like, well, a closely knit community is protective against substance use. Which, well, maybe, maybe not. It's actually protective principally when people in that neighborhood actually think substance use is not a good thing. If you're actually in a neighborhood that's closely knit, where people think substance use is a good thing, then people are going to use substances even more. So that really gets at the complexity of these overlapping constructs, that we need to recognize that social norms and social cohesion both work together, and social cohesion can be a good or a bad thing. Social norms can be a good or bad thing, depending on the other one. So I thought that was a really important illustration of how one cannot understand social environment without understanding the fullness of the social environment and how it's related to substance use. And then the other aspect of this is, well, what social environment are you talking about? What are we talking about for a social environment? Do you mean neighborhood? Do you mean my census tract? Do you mean a cluster of census tracts? Do you mean my town? And all of these, this is a picture of New York City. I'm looking at different neighborhoods in New York City, just to make a point that there are very different definitions of what a construct around us is. And we've done studies all over the country where we can show, for example, what is a meaningful neighborhood in Detroit, dramatically different than what is a meaningful neighborhood in Texas, dramatically different than what is a meaningful neighborhood in New York. So the level at which the environment around us matters to us for our risk of using substances and substance use disorder changes dramatically from place to place. Now, if you've been paying attention so far, this is where you might throw your hands up in the air because you're saying, well, he's saying everything's difficult, everything's complicated, everything depends. That's true, but I don't think that needs to get in the way of us sort of trying to understand it better. And I actually think it actually makes it interesting, but it certainly shows that from a therapeutic point of view, from a therapeutic lens that takes context into account in helping people with substance use disorders, it requires intellectual dexterity to think about what is the context that matters for the individual and what it is about the context that matters for the individual. Because what matters, the context that matters for one individual X and the features of the context that matters for individual X may be quite different than the context that matter for individual Y and the features of context that matter for individual Y. And then the third point is concepts. So I want to talk about ubiquity, counterfactuals, and life course. So let me start with ubiquity. One of the challenges that I think we face in the field of substance use and substance use disorders is that a lot of the elements of the social context around us are everywhere. As a result, we do not see them. So let me show you what I mean by that. I'll start with a simple example. This is just an illustration. This is from a classic study. This from classic has nothing to do with substance use. This is just a classic study looking at communities with water hardness, how hard the water is, and death from heart disease. This is in the United Kingdom, okay? So you see over here on the x-axis, water gets harder, and this is heart disease death. Now, what do you see when you look at that picture? Well, what you see, right, is that there's a line going through here, right? Everybody see it? Like you can use the sophisticated statistical tool of your eyeball, and you can see there's a best fit line. You know, I can run fancy models, but it'll show exactly the same thing you're seeing with your eyeball, right? The harder the water, the less the heart disease rate. Does everybody see that? Right? Now, you're like, okay, that's fine, right? So we can see that relationship. Now, suppose for a second, so like, let's accept that this is correct, which it actually is, that where there's harder water, there's less heart disease, okay? Now, suppose for a second that I only gave you these data. Now, what's the relationship? Hard to say, right? Nothing, right? Like this is, I don't know, like there's no clear line there, right? So suppose you're in this environment where the water is all soft here. Are you even for a second going to suspect that water hardness has anything to do with heart disease? No, you're not. Because your environment is all soft water. You have no variability. You're going to think, well, it's just, it must be something else. There's no way water hardness has anything to do with this because I see no relationship between it and heart disease in my environment because I don't have this full picture. Now, you might say, well, that's silly. Why would you ever give me half the data? Well, here's why I give you half the data. Because the people to the left of the line are in Wales. People to the right of the line are in England. So it's perfectly reasonable to be in Wales and to see only that. And if you're in Wales, you're never going to suspect that water hardness makes any difference whatsoever. Now, I'm using that as an illustration. Now, you're saying, well, what has this got to do with substance use? That's what I care about. Well, it has everything to do with substance use. So here's an example. Here is temperature and death from drug overdose. How often do we think of temperature as linked to drug overdose? Well, because temperature is ubiquitous, right? And we've done studies, and others have done studies showing that temperature is linked to drug overdose. In fact, at higher temperatures, you have drug overdose deaths that are substantially higher than lower temperatures. Now, there's many reasons for that, but we don't think about it because temperature is ubiquitous. It's everywhere around us, right? It's like being in Wales where all the water is soft. So you don't think about the fact that water hardness has anything to do with your heart disease. Similarly, if you're in a place where temperature is constantly warm, you don't think about the fact that that's actually one of the factors that's driving drug overdose deaths. So ubiquity, because we're dealing with social processes that are very common, often masks and puts blinders in front of us in terms of not seeing what really is driving things. Life course. Let me talk about life course. You know, one of the challenges with dealing with substance use and substance use disorders is that we tend to see them from a clinical perspective, like in adults. You can have adolescents, adults, right? And we're human, and we see things as snapshots. We're like, 42 years old, has a opiate dependence, right? Well, the 42-year-old has opiate dependence has had a life course before then, which probably was intertwined with all these factors I'm talking about that shaped her opiate dependence. What I'm showing you here is income. This is trajectories of household income over time. And what you see is people's incomes like fluctuate. People go up, people go down, people stay the same. I'm using this as an illustration of how we wind our way into and out of risk patterns throughout our life. And all of that ultimately sums up into the manifestation of a particular phenotype. And that phenotype here, in this case, I'm talking about substance use disorder, at a particular point in time. And this ties back to the Blind Willie Johnson story, that it's impossible to fully understand the manifestation of substance use disorder without understanding the life course that led to it. I'll show you this as an example. This is binge drinking. It's from a study that we had done looking at binge drinking. And what we looked at is two forces: child maltreatment and being in a neighborhood that was not cohesive. So look at the 4 different groups and look at the group on the left. Overwhelmingly more, like 4-fold more binge drinking. And these are people who had maltreatment as children and were living in a not closely knit neighborhood. You see how extraordinarily, as children, by the way, how extraordinarily higher that percent of incident binge drinking is. So how can we even wrap our brain around the pathology, here in this case we're dealing with binge drinking, around an alcohol use disorder, without at least understanding how that is nested in, produced by, and generated by the neighborhood and one's childhood. Fundamentally, life course is an inextricable part of what produces substance use disorders as adulthood. Okay, so that's really my framing of why social environment matters, thinking about the theory, thinking about the intuition, thinking about the evidence, and my framing of the bounds of our understanding, which hopefully then gives you a sense of what it is we understand, but it's surrounded by the bounds of our understanding. Now I want to talk a little bit about the moment. I want to talk about the challenges of the moment we're living in, and I want to wrap up with an overall framework. Because we are living in a moment of particular concern for anybody who's interested in behavioral disorders, including substance use disorders. Why are we doing that? Because we are living in a moment. We're living in a moment because we have lived in a moment in the past year, going on to, we're now at about a year really, of enormous social and economic disruption. This is a picture of Times Square with nobody in it, fundamentally. We have lived in the past year in a way that none of us, nobody on this call has lived through anything like this. So this is a moment of enormous social and economic disruption. So if I'm here talking about a foundational perspective on social environment, how social environment affects substance use, we need to recognize that we are living in a moment where there is enormous social disruption that is going to affect substance use and substance use disorder. This is unemployment. This is unemployment in the US, and just showing you this over sort of 5-year period. We had this enormous rise in unemployment. We have our employment dropped to the lowest level since 1975, which is 45 years ago. We have had the worst recession, essentially, that we've had in 100 years. There was data that just came out from, not nationally, but the United Kingdom, which I thought really grounded today, because the UK has longer records than all of us. The UK's economy in 2000 was the worst it had ever done since 1709. Just to give you a sense of the moment. Of course, we weren't even a country then, 1709. So this is a moment of enormous peril for substance use disorders, behavioral disorders, mental health, mood anxiety disorders, because there are disruptions in the social environment that are almost certainly going to be affecting the full range of behavioral disorders. I am sure you are seeing some of that now, those of you who are in practice, and we're going to be seeing much more of it in the coming months and years. This is drug overdoses, a lot of them opioid overdoses. You know, we were at a point where at 2019, we were beginning to see a plateau of the opioid overdose epidemic. We're beginning to see a plateau, and which, I mean, the opioid epidemic, as you all know, really accelerated over 20 years. It was beginning to plateau until this is 2020. These are 2020 numbers. These are where drug-related deaths have increased. So state after state after state, we're seeing 10, 20, 30, 50% increase in drug overdoses. So the data on this are still not out about the year, but the expectation is, certainly my expectation is, that we're going to find a reversal in drug overdose in the gains we had made on drug overdose. Now, why is that? It's because we changed the social environment, right? We changed the elements of the social environment that ultimately influence drug overdose. But that ultimately is going to manifest in a change in the phenotypic presentation and the people who those in practice see on a day-to-day basis. And then, you know, I just want to make a point that we as a country, despite the moment, are sort of bad at this. Like, we're not investing enough in dealing with, in providing health assistance for these issues. This is a map. I just find this sort of it's sobering, right? This looks at local government spending on policing and health. The red, you're spending more on policing, the blue is spending more on health. And you see the vast majority of the country spending more on policing than you are on health. It's not this is in no way an indictment of saying we shouldn't be spending on policing at all. It simply says that we're not spending enough on health. It's we are about to enter a phase where behavioral disorders, of which substance use disorders are a subset, are going to be the next pandemic after the COVID pandemic. And to my mind, it is a shame that we don't understand this at the national level. So I'm going to end with a population health approach. I'm going to end with a population health approach and then really open it up for questions, because I want to frame this by pointing out why it is that I do not think that one can meaningfully engage intellectually or practically with substance use disorders without understanding the forces I'm talking about now, without taking a foundational approach, as was the talk I was asked to present, to substance use disorders. So suppose, I'm going to show you a picture of population, okay? And suppose we have some people who are exposed to a social condition that is causing more use of substances. Let's say it's poverty, it doesn't matter what it is. So those are the red people, okay? The blue people are not exposed. So the red people have more of the social condition, let's say poverty, the blue people do not have that condition. Now, we all know that you're going to have substance use disorder, let's say alcohol abuse, in the whole population. You have more alcohol abuse among those who are exposed. So this is the excess or the alcohol abuse. More among the red people than among the blue people, but you also have alcohol abuse among the blue people, because you all know that any social causative condition is not exclusive. It doesn't mean it's only people who are exposed to it who actually have the problem. Other people also have the problem, right? So that's where the X's are. That's the world. So think of it as the world. The red could be poverty, the blue could be not poverty, and the X could be alcohol abuse. So there are more X's among the red, but there are also some X's among the blue. Now, why am I showing you this? I'm showing you this to say this. Let me go back to the risk factor, whatever it is, let's say levels of poverty, and how many people have it, right? You have a few people who have who are really poor, a few people who are really rich, and most people are somewhere in the middle, right? That's just the reality. But if we were to say, I care only about people with the social factor, and I'm going to take only those at extreme risk, which you could do. You say, I'm going to cut off those people, and I'm only going to deal with people at extreme risk. You could do that, and you could move those people out of the way. You could treat those people, only those people with extreme risk. The problem with that approach is as follows, is that you've dealt with the red people only. You've said, I'm only going to deal with the red people. And you've tried to help the red people, which is fine, but you've ignored all the blue people who also might have alcohol abuse. The other approach is you take the whole population and you try to shift it, where you try to lift the economic consequences for everybody. And you can only do that if you understand these social conditions and you understand that at a moment like this, lifting economic stressors is medical treatment. Helping people with stable housing is effectively medical treatment because you're shifting the whole population. And you could do that. And if you do that, you have the whole population. And what the strategy does is you are reducing the number of reds because now you have fewer people who are heavily exposed. And by doing that, you are reducing the number of people with excess or number of people with disorder. So fundamentally, what that says foundationally is that you cannot deal with the whole population if you only focus on people at extreme risk when you recognize that the population is influenced by a full range of social and environmental exposures. And you need to think about the full range of social environment. I'll end with this one slide. This is just one slide to make the case. And just to illustrate this point, moving ahead from substance use, I'm just end on a metaphor. And this one is about blood pressure, just very simply, just because blood pressure is sort of good and linear, right? So let's deal with blood pressure. You have systolic blood pressure over here and percent of people with blood pressure. So look at the curve, the black curve right here, right? So you have some people who have high blood pressure, some people have low blood pressure, most people are somewhere in the middle. So how do we deal with high blood pressure? Well, you could actually take these people over here who have high blood pressure, get them screened by a doctor and give them a pill, right? That's typically what we do. But now, if you take a step back and you look out, who are the people in the black curve? Well, those people are people living in London. They were civil servants living in London. But look at the dotted curve. These were Kenyans. Now, what do you see here? Well, the curve is all shifted. It's just in a different place altogether. So all of a sudden that says, maybe what we should be doing is not just treating the Londoners who have high blood pressure. We should actually be thinking about how we can get the London curve to look like the Kenyan curve. And I think that applies equally well to any notion of substance use and substance use disorders that are linked to social environments. And frankly, they all are linked to social environments. That our collective task in practice and policy and in scholarship should be to recognize that we can create a curve that is more conducive to healthier living, to less burden of substance use, rather than simply focusing only on the extreme cases. Now, of course, in our treatment, in our clinical practice, one has to focus on extreme cases. That's what presents. But presumably you asked me to speak because you understand at some intuitive level or through a theoretical level or through a level of thinking about the concepts that there is a full set of factors in the social environment that drive substance use. And without understanding them, we are never going to properly address the challenge of substance use disorders in the community.